So what is the synapse? Just that specialized point of contact between a neuron and oftentimes another neuron, but it could be another type of cell, like a muscle cell, cardiac cell, a gland even. So some neurons, their final termination is going to be on a effector organ. But most of our connections are between neurons. We have so many neurons in our body that are in all those interneurons. Information is transmitted from one neuron to another postsynaptic neuron or cell. Types of synapses. So we're going to start with the least common type of synapse. It's called an electrical synapse. Okay, these are through these little pores called gap junctions. Okay, the pre and postsynaptic membranes get really, really close together at these gap junctions, and there's an actual protein channel that's connecting, like as a tube, between the two membranes. Those proteins are called connexins because they literally connect the two cell membranes together, but they're really close. They're not quite touching, but they're really close. And they're big and fast and allows big, fast conduction of ions through those channels or electrical charge through those channels. So you often see these in things like cardiac and smooth muscle cells where you get large coordinated contractions of lots of cells at the same time. So a heart, you're going to contract, a whole ventricle at one time, and it has to happen in a pretty quick coordinated fashion. So you spread that charge over that entire ventricle, and boom, that whole ventricle goes. Those are through gap junctions. It allows that action potential to spread very quickly and create that. Same thing with some glands. That's just showing you the gap junction and the connexin, showing you that open pore system and that really small, narrow space at that gap junction between the two cell membranes, just 3.5 nanometers at that gap junction, and it's closer to 20 nanometers as you get away from that section. So that's electrical synapses. Now we're going to talk about chemical synapses, which is the one we're going to spend the most time on because that's the probably most common types of synapse or connections between neurons and muscle cells and glands. So most synaptic transmission in the human nervous system, we have a presynaptic terminal. So these are at the end of the axons. Okay, these presynaptic terminals. They're also known as just an axon terminal. So presynaptic terminal, an axon terminal, or terminal bouton are the three interchangeable terms for that. Then you have a cleft or a space between that and the next cell. Okay? The next cell has a postsynaptic terminal or postsynaptic membrane. Okay? That is the membrane of the target neuron, target muscle cell, target gland. Okay? That's the postsynaptic terminal. It's usually kind of a specialized area or site that has a higher density of receptors for whatever neurotransmitter is being released into that cleft. Then you have the neurotransmitters, okay, which are the chemicals that contain the message, so to speak, and small vesicles that are delivered and into the synaptic cleft. You can have different areas of connection. So down at the bottom here, you can have an axosomatic chemical synapse. So that's where an axon of one neuron is meeting up with the actual cell body of the next neuron or cell. Okay, so it's axosomatic. You can have an axodendritic, where you have the axon connecting with the dendrite, or you can have axoaxonic, where an axon of one cell is actually communicating with the axon of another neuron. Very basic schematic here of the presynaptic terminal here, postsynaptic terminal, synaptic vesicles with neurotransmitter, a little exocytosis going on here with neurotransmitter, binding to specialized receptor sites, okay, on the postsynaptic membrane. This is just representing those different types of connections you can have with these chemical synapses. So here's the axosomatic, an axon directly communicating with that cell membrane at the cell body. Here's an axodendritic. And here's an axoaxonic. Probably the biggest proportion are going to be axodendritic because you have so many axons out there with all those little spines that there's just more surface area of dendrites, so they're likely to encounter other axons more easily than some of these other regions. But just understand that you can have these connections at different locations, and especially this axoaxonic connection can influence this guy's communication with the next neuron or cell down the line. So that helps when we'll get to that in a few minutes here and talk about how that can influence that. Let's talk about the summary of events that occur at this chemical synapse that, help communicate between one cell to the other. So you have an action potential somewhere in your nervous system that has started, okay? It reaches the presynaptic terminal. That action potential coming down the axon, you're getting that flip-flop of charges, right? The sodium comes in, potassium goes out, and we get that flip-flop of charges from negative to positive. When it gets down to the axon terminal, there is voltage-gated calcium channels down there. Just like at the axon hillock, we had those voltage-gated sodium channels, but we have some voltage-gated calcium channels, a much greater proportion down at that presynaptic terminal. That causes those to open. Calcium comes in. Calcium triggers the synaptic vesicles to help them bind to the presynaptic membrane to then release their neurotransmitters, which go across the cleft, bind temporarily to the postsynaptic membrane. Okay, it's kind of a timing feature associated with the different neurotransmitters and the different types of receptors. And then the neurotransmitter is released from its receptor. It's broken down in the cleft by typically enzymes, or it's actually reuptaked by the presynaptic terminal in the form of endocytosis. So it can recycle some of those parts, okay, some of those amino acids and subunits of the chemicals, of the neurotransmitters. And that ends the transmission. Once the receptor unbinds from its, from the protein channel, that closes the channel and stops the process from happening. Okay. So this is just showing you that process going. So we have our charges changing here, getting more positive on the inside and negative on the outside. Then once that reaches to the end of the presynaptic terminal here, we see we now have negative on the outside, positive in here. That opens calcium, voltage-gated calcium channels to allow the calcium to come in from the outside, and that triggers synaptic vesicles to move to the membrane of the presynaptic vesicle, a presynaptic terminal. They release the neurotransmitter, goes across the synaptic cleft, and then we see binding here, which opens ligand-gated, these are ligand-gated protein channels, right? Because the neurotransmitter is the ligand. That causes, it could be chloride, it could be sodium, it could be calcium, but when we think about action potentials and nerve transmission, let's say it's a sodium channel, ligand-gated sodium channel, that causes the next cell to depolarize some, if it's an excitatory postsynaptic potential. But we don't know if it's going to cause an action potential yet. We typically need some summation of other signals coming in to create enough of a depolarization so that you change that enough so that the voltage-gated sodium channels down the axon hillock finally click open. Okay? So that's the typical sequence of events. Then the positive charges come through, like we mentioned. And then the receptor, the neurotransmitter unbinds from the receptor, is recycled or broken down or taken away by the glial cells, buffered, and then everything resets. Okay? So let's talk about those local potentials again. Okay? And we can have local potentials, so you've got this one little area of communication on the cell that causes a localized either depolarization or hyperpolarization. Okay? Things that cause a depolarization are excitatory, right? They start to depolarize the cell, making it more positive on the inside or less negative on the inside, getting it closer to threshold. Okay? If you get enough of these excitatory postsynaptic potentials, also called EPSPs, you will get summation and then the all or nothing action potential, which is causing those voltage-gated sodium channels to open at the axon hillock. If you don't, nothing happens. It just doesn't quite get there and it goes away. But so not all excitatory postsynaptic potentials lead to an action potential. Only if enough of them arrive on that cell at the same time, temporally, spatially summate to get your action potential. But we also have, we usually think about excitation. We always think about this action potential and excitation. But remember I said for every system in your body, there's a way to turn it up, there's a way to turn it down. And usually I think about like a volume, usually we're in the middle somewhere. And so our body then from the middle can go up or down. And that's the same thing with nervous system, cardiac systems, most of our systems are kind of set in the middle. Same with our nervous system. So we can have excitation from where the base level it's at, or we can have inhibition. And so we also have things called inhibitory postsynaptic potentials. So sometimes you don't want neurons to fire. There's times when we talk about pain pathways, we talk about chronic slow pain, sometimes your body, you don't want those pathways to fire. So you actually, there's chemicals and neurotransmitters that cause inhibition of those pathways so you feel less pain. And they create inhibitory postsynaptic potentials, okay? So they cause hyperpolarization, so the inside of the cell gets even more negative, so it's harder to excite it and elicit that pain response or whatever it's trying to inhibit. Typically, those involve one of two mechanisms. Either you allow some chloride to come in. Chloride is at a higher concentration on the outside of the cell, in extracellular space. You allowed some negative ions to come in and make it even more negative on the inside. So it hyperpolarizes it, makes it, from minus 70 down to minus 90 millivolts when you allow a little more chloride in. Or you let a little bit, you open some more potassium channels. And since potassium is much higher on the inside than the outside, it wants to go out. And it's already negative on the inside because you've got all those extra sodiums, but you've got such a high concentration gradient, some potassium will go out and even take you even more negative because you're pulling positive charges out, even beyond what the leak channels are letting out, okay? And those two processes are kind of what govern the excitability of the nervous system, influence the overall excitability of any two neurons or even just circuits of neurons too. A lot of times we have neurons that work in circuits or groups, okay? And you can influence whole groups of neurons and circuits of neurons through these mechanisms. So that's just showing this process here. So here's an excitatory postsynaptic potential on your left. Sodium is on the outside here at a higher concentration, and we've got positive on the outside, but so we've got a ligand, a neurotransmitter binds to a ligand-gated protein channel. Some sodium comes in this little region here, and we get a little blip. We get a little less negative, more positive, because we got positive charges coming in. That's an EPSP, okay? You get enough of these happening, we get threshold, and then we get an action potential. On the flip side, the reverse of that is chloride here. So here's a neurotransmitter that actually causes some ligand-gated chloride channels to open. Negative charges come in. It's already negative in here, but because you've got a strong concentration gradient, this negative chloride ion can still move with its concentration gradient to the inside of the cell, even though you don't have an electrical gradient here. But it comes in and makes it even more negative. So we go down from minus 70 down to minus, say, 90 millivolts. And so it's harder to get up to, it's harder to get to threshold from here to here than definitely it is from here to here, So you've gotten closer to threshold here, you've gotten further away from threshold here. So let's talk about this concept now that we kind of understand this, excitatory possibilities and inhibitory, is this thing called presynaptic facilitation inhibition. This is when the amount of neurotransmitter that is released at a connection point is either increased or decreased, but it's influenced by the previous activity of an axo-axonic synapse, okay? So let's start with presynaptic facilitation. So here's this axo-axonic connection right here. A presynaptic facilitation, what it does is this presynaptic connection, there's an action potential coming down this axon, and what this will do, this will actually prime this area right here so that when this action potential hits, it's already depolarized some there before it even gets there. And so you're going to, when that action potential gets there, even though it's technically an all or nothing, it's actually going to enhance and actually cause a little bit more or greater release of the neurotransmitter into the synaptic cleft. So it's kind of priming that system so when an action potential does get there, it's going to even create a little bit stronger response or release of neurotransmitter. So what it does typically, it causes a slight depolarization through the influx of calcium. So this actually opens, in this case, most of the time, some ligand-gated calcium channels that allow some calcium to come in, which calcium is really critical for binding of those synaptic vesicles. It also depolarizes a little bit because little positive charges are coming in, but it also starts moving those synaptic vesicles ready right at the membrane, so as soon as the action potential gets there, boom, it's going to make sure it releases the maximum amount of neurotransmitter into the synaptic cleft and enhancing, so you see all these extra, they're trying to show you lots and lots of neurotransmitters, so that the more neurotransmitter you have, the better chance of getting binding to every receptor that's on the other side. Typically, when you release neurotransmitter, you don't bind into every receptor, opening on that other side, but this will increase your odds of getting more maximal binding and then getting into a larger opening of more ligand-gated sodium channels on the next neuron, increasing that EPSP on the next one. So this enhances this EPSP here, excitatory postsynaptic potential, goes up because you've got more neurotransmitter being released. But all this is just ways that we can modify and tune the nervous system to make circuits of nerves either more hyper or excitable, ready for action, or down-regulated. Okay? This is neuroplasticity going on. And the more you say, if you're practicing a new skill, and you are activating certain neurons in a certain sequence and certain groups of neurons to learn a new, golf swing or something like that, over time, you will develop some of these systems that are priming those circuits to work like that without you even thinking about it. It works smoothly, and you're priming those circuitry. But at the same time, there may be other muscle groups or there may be other pathways right next to it that, if you're gripping that club too strongly and you're, using all these extra muscles that you don't need to be using, eventually what you learn, and part of the learning is actually changes in your physiology, is that you get other neurons nearby that are downregulated, less excitable, so you don't overuse muscles. You only use the muscles you really need to do the smooth golf swing. So this is just one aspect of how the nervous system works to modify and tweak output. It's part of it, yeah. So this is really some of this is part of what's going on in muscle memory. This is happening in the hippocampus, the basal ganglia, the cerebellum, and that's what takes time, is to develop the repetition you need, the 10,000 cycles of doing something or practice cycles to get more permanent plastic changes in your nervous system that are resistant to change. And then this is presynaptic inhibition, so we can have just the opposite. So in this case, this cell is binding to some of these receptors that causes slight hyperpolarization. So it might allow some chloride ions, some negatively charged chloride ions to come in. So when the action potential gets here, it hits that area that's it's even more depolarized, and you have a less strong response from that action potential. You're going to have less neurotransmitter released into the synaptic cleft, and so you're not going to get a lot of these receptor sites on the postsynaptic cell filled, so you're going to have a smaller, EPSP. It's going to downregulate that EPSP. So that's presynaptic inhibition. And like I was telling you, some of our natural pain inhibitory circuits use presynaptic inhibition using some specialized. That's where some of our endorphins and calphins and those kind of things, some of these neurotransmitters and opiate receptors help to cause some of this presynaptic inhibition in circuits that influence pain pathways. Okay? All right, any questions on that? Let's talk about the receptors themselves. We have ligand-gated ion channels, okay? We've talked about these a bunch, proteins that function like a gate. When the neurotransmitter binds, they open. They tend to be fast-acting. It binds, they open, it unbinds, it closes really quick, milliseconds here. We're talking just a 1 to 2 millisecond kind of thing going on here. They are inactivated once that neurotransmitter releases. This is the majority of synaptic activity is mediated by ligand-gated ion channels. So a lot of what our nervous system does is pretty quick and fast-acting. Okay? The neurotransmitter is the ligand. And there's the channel, and it's open. The other major kind of type of receptor is what's called a G protein mediated receptor or modulator, okay? When you think about modulation, you're modulating things, and that's typically over a greater, longer period of time that you're modulating the system. It's more complex in how they work. They can work almost go over the different ways that G protein mediated receptors work. They're slower acting. These take seconds to minutes to even hours that these can last, and they can cause long-term plastic changes in your cell so that, you know, some long-term even like activating genes, so you add more protein channels, more receptor sites to your cell membrane, or downregulating your cell, removing receptors and those kind of things, decreasing metabolic activity in the cells, and over long periods of time, you can change your cell dramatically and relatively permanently as long as you continue to either practice a skill or stimulate the system in a similar way, okay? These are involved in what's called the second messenger system. We'll go over the second messenger system here in a minute. So here's one way. This is not the only way. We're going to go over some other ways that the G protein mediated receptors will work. So here's this G protein mediated receptor. The neurotransmitter binds. You typically have a complex of protein that's part of this process that's called the G protein. Okay, it's called G protein mediated receptors. And it's usually composed of 3 parts. It's got an alpha, beta, and gamma subcomponents. Okay? One way it can work is that when the neurotransmitter binds, it actually causes a conformational change in this G protein. And in this case, the alpha subunit directly is released and might migrate or interact with a close by protein channel that causes it to open. Or it could do the opposite. It could keep it closed, so it's less likely to open. In this case, it caused it to open. And that's typically going to happen for a longer period of time than our typical ligand-gated channel. This may be a protein-mediated, G protein-mediated channel that's going to stay open for several minutes or several seconds versus milliseconds, okay? And so before this unbinds and goes back to its spot and resets itself, okay? This is one way that the G protein-mediated receptors can function. But let's talk about other ways. So the second messenger system, the G protein activates an intracellular target protein, which could be a protein channel. Like this is actually the alpha chain actually activated this protein channel. Or it could be an enzyme, typically, that then activates and creates the second messenger. So we'll talk about that in a second. So this is what it could do. Second messenger system may initiate the following. These are the different things it can do. Once it produces the second messenger, that second messenger can open a membrane channel or ion channel, kind of like this. In this case, the alpha protein is kind of like the second messenger, but this is not really this. We'll get to a second what the second messenger really is here. It can activate genes. So it can actually, that second messenger that's created can go into the cell nucleus and activate genes and turn them on to do things like increase synthesis of cellular products, make more mitochondria, add more protein channels to the membrane, increase receptor sites, decrease receptor sites, take away, you know, can upregulate or downregulate sometimes, okay? The other thing it does is it modulates calcium concentrations within the cell. Calcium is very important. The more calcium you have within your cell, typically the metabolic activity of your cell goes up, the less it goes down. So it regulates overall metabolic, the engines and activity of the cell overall. Those are the ways that the second messenger system can work because they have these more long-term broad effects on the cell, making it less excitable, more excitable, okay? So this is probably how, this is a little bit, you know, how we look at this G protein mediated response here in the second messenger system. So here is, you know, the schematic we showed you before. They had the G protein basically connected or right off the side of this receptor. It's not always like that. It's just nearby. It doesn't necessarily always just touching it or a total subcomponent of it. But here's our, alpha, beta, gamma, 3 parts of this G protein, okay? So what typically happens is a neurotransmitter binds, that activates the G protein. The G protein, or subunit of that G protein, so maybe that alpha chain, comes over here, talks to this enzyme that's right next to it or nearby somewhere in the cell and says, hey, enzyme, I need you to start increasing chemical reactions to produce this more neurotransmitter or help me build protein channels nearby. So it's telling the enzyme to make the substances, the molecules that are going to be necessary to actually create the action. And the enzyme itself, these are the second messengers. The G protein is the first messenger. Does that make sense? Then whatever the G protein tells this enzyme to do and produce is the second messenger. So these second messengers are what's going to go and make more protein channels, go into the cell nucleus and activate genes, okay? So in this case, this alpha chain moving is the first messenger. This is a G protein mediated response, but it's just using one messenger, the alpha chain. But a lot of it is using the G protein, one of the chains, to go activate another enzyme typically that then creates the second messenger. So the G protein is the first messenger, then whatever the enzyme that's activated creates is the second messenger. So here's from your book that summarizes these events. So here's our fast-acting ligand-gated channels, the most common we see. Briefly opens ion channels that span the membrane. Neurotransmitter binds, opens the channel, quick, releases, off, closes, okay? And that causes either local depolarization or hyperpolarization, so excitatory or inhibitory postsynaptic membrane potentials. That's the most common. But then here's the G protein mediated receptors. So when a neurotransmitter binds to a G protein mediated receptor, it can do a number of things. It can, by just using the alpha chain, which is the first messenger, or second messengers, you can cause prolonged opening of ion channels that span the membrane, seconds, minutes, kind of thing typically. And that causes also local depolarization or hyperpolarization in the next cell, but more long-term. G protein mediators through the second messenger system only, not by just the alpha chain, but some second messenger that's been produced or activated by the G protein chain that tells the enzyme to make something that then goes to the cell nucleus, can activate genes that can do more big-time regulatory increasing rate of synthesis of specific cellular products, but we should also probably say decrease as well. It's not always an increase. It can also cause decreases as well. The other way that you can have is again, another second messenger system that can modulate calcium levels inside the cell. And that affects overall cell metabolism, up or down. Okay? More calcium, higher metabolic rate of the cell, lower calcium, lower metabolic rate. All these are just ways to manipulate excitability and interaction between neurons and muscle cells and glands and those kind of things so that you can have a graded effect. You don't have to memorize the specific. These are just examples of second messenger systems, okay? You don't need to memorize each step in this, but I want you to understand, like, here's some common examples of how the second messenger system works. And I don't even know that your latest textbook, I think the third edition has some of these in the back as an appendix, but I don't think the fourth edition of your Lundy-Eklund book has these. So one of the second messenger system that's commonly talked about is called the cyclic AMP system, or the cyclic adenosine monophosphate system, this cyclic AMP system. So what happens is you have norepinephrine, neurotransmitter, norepinephrine, binds on a G protein mediated receptor on a cardiac muscle cell, okay? The G protein, one of those chains from the G protein, goes over and activates an enzyme that's embedded in the cell membrane called adenyl cyclase, okay? Adenyl cyclase creates the second messenger, which is adenyl cyclase monophosphate, or adenosine monophosphate, cyclic AMP. Okay, so cyclic AMP, this is the second messenger. That causes phosphorylation and opening of calcium channels. Okay, so calcium channels open, and we know calcium plays a critical role in the contraction of cardiac muscle cells, and that causes the heart to beat faster and more strongly. This is part of your sympathetic nervous system here. So these are sympathetic nerves that are doing this to your cardiac muscles. Okay, so ramps up your cardiac rate and contractibility through this cyclic AMP process using a second messenger system. And there's a little bit of, it's a little delayed. You know, when you start to run and you activate your sympathetic nervous system, it's not like this instantaneous, there's a ramping up of the heart rate, and then there's a ramping down of the heart rate, because you don't want your heart just to boom, turn on and off so quickly that your other vascular system can't respond to it. And so this kind of allows the ramp up and the slow down, and then part of that is because of this is a little bit of a slower, longer lasting process to get the heart rate started, but then it turns off slower too, so it's kind of like ramps that up. So another common second messenger system that you'll hear about is the arachidonic acid second messenger system. So in this case, this is when you have an inflammatory response. So what happens is you might have some histamine release. So let's say you have a trauma. You get scratched or something in your tissue. There is histamine in some of your cells of your skin and your subcutaneous tissue. Histamine is released. That histamine might bind to some nerves that are nearby on ligand-gated channels that are specific to histamine. They binds to that, causes the receptor and G protein mediated receptor to get activated. That causes an increase in an enzyme called phospholipase A2, which then creates arachidonic acid. That enzyme makes arachidonic acid within the cell. That arachidonic acid causes an increased production of the cell to create prostaglandins. Those prostaglandins are released from that cell into the nearby area and causes vasodilation. And that's where you get the swelling and the redness and so forth. That's part of the process of getting this inflammation. Okay? The reason this is somewhat important is because aspirin and other non-steroidal anti-inflammatories, they inhibit this enzyme phospholipase A2. So you can't create the arachidonic acid, so that decreases prostaglandin synthesis and reduces the swelling and inflammation associated with that. So that's just something that is pretty common that you see out there. That's the mechanism of a lot of NSAIDs, is to reduce that production of, or the activity of that phospholipase A2 enzyme. Yeah?
So overall, for the second messenger to occur, you usually have a unit of a neurotransmitter, a G protein, or a receptor. And then that G protein
Yep.
activates the target protein, which is usually an enzyme.
Yes.
And then that enzyme activates the second messenger.
Correct. Or makes or builds the second messenger, activates the second messenger. Yes. The G protein is, or some subunit of the G protein is usually the first messenger.
Okay.
And then it goes and tells the enzyme to create another, molecule or some type of thing that's the second messenger. Yeah, good. All right. Now let's talk about, yeah.
So since that's a second messenger system, is that generally why you get swelling like the next day or like hours later or something like that, because it's like a slow acting process?
Yeah, it may take even just a few minutes, but it could go on for days and so forth. So it is it comes on a little slower and stays on a little longer. It's not the only reason, but it's part of the reason, yeah. It's a modulation of activity in that area of the cells. And these G protein mediated processes aren't just with neurons, you're seeing it with other types of cells that can use these same processes to influence how cells respond and act. All righty. Let's do this. Maybe this is a good time. We'll just take a quick 10-minute break, come back, bang out the rest, watch a little quick video, and then we'll be done for the day. All right, let's finish this up. So let's talk about, we talked about synapses and types of synapses. Now we're going to talk about the neurotransmitters themselves and focus in on that a little bit. What are these things we call neurotransmitters or slash neuromodulators? Okay. You know, most neurotransmitters, modulators are classified as either amino acids or their derivatives, amines and peptides. The one exception is the cholinergic transmitter acetylcholine. There's also nitrous oxide as a neurotransmitter. It's a gas, so it doesn't fit that. That's that other on there you saw. Neuromodulators are still fit under the big category. It's still a neurotransmitter, but neuromodulators, you know, tend to be longer acting, and they tend to activate those G protein receptors. Okay, that's what neuromodulators tend to do. But so here's kind of how they breaks out. So the common neurotransmitters slash neuromodulators. So neurotransmitters are these: acetylcholine, but in the peripheral nervous system, it's fast-acting acetylcholine. That's where it says fast-acting, and this is most of the time because you'll see acetylcholine pops up as a neuromodulator in the central nervous system, so there's sometimes exceptions to these. So acetylcholine is a fast-acting neurotransmitter, causes a ligand-gated channel to open briefly and close. Okay, same with GABA, glycine, and glutamate. Those are your primary fast-acting neurotransmitters. GABA, glycine, and glutamate are all central nervous system. Acetylcholine's peripheral nervous system. And then the neuromodulators, the G proteins, one that activate the G protein receptors, are dopamine, serotonin, norepinephrine, substance P, endorphins as a whole class, and then acetylcholine in the central nervous system acts as a neuromodulator. So when we talk about influencing overall brain activity or spinal cord activity or brainstem activity, there are certain regions, most of them are actually in the brainstem, where you have some large pools or nuclei of cell bodies that have axons that project up to the brain or down to the spinal cord to influence overall activity of any of the nerves interacting in a general area. Does that make sense? And so, and a lot of these are more the G protein mediated pathways. So serotonin, for example, there's a couple nuclei, the raphe nuclei, that are inside the brainstem. We'll see those when we get to cross sections and talk about brainstem. So there's cell bodies in here that project axons through pretty vast circuitry within the brain, cerebellum even, okay, and then also project down into the spinal cord and influence some motor output, okay. And so serotonin can influence large networks of neurons and, you know, upregulate, downregulate overall activity of these different networks of neurons, okay. And that goes the same is true with all these different ones. So then norepinephrine here, it also has several nuclei, the locus coeruleus, and then the medial reticular zone nuclei right here. Again, brainstem nuclei that can project down into the spinal cord or project up into the cerebrum and influence large networks of neurons in their overall activity. Acetylcholine, there's a pedunculopontine nucleus right here in the brainstem. It actually goes down on the spinal cord, influences some activity of the spinal cord, but it also projects particularly up into this medial forebrain bundle right here that is influenced for some cognitive and decision-making things and some reward centers as well. And then we have dopamine. Dopamine right here, its primary cell bodies are located, most of the neurons that produce dopamine are in this ventral tegmental area, the front part of the tegmentum of the midbrain, okay, in an area there. And there's parts of it that project up to the basal ganglia and help motor circuitry, but then there's lots of parts that project to the hippocampus for memory, and also parts that project to this medial forebrain bundle and this infraorbital area that's also for the reward centers of our brain, okay? So we're going to go through each of these real quickly and just talk about their basic function, okay? So let's talk about acetylcholine. Acetylcholine This is the one that's not an amine, a peptide, or amino acid. Acetylcholine is that exception. It plays a major role in transmitting information in the peripheral nervous system. It's the fast-acting neurotransmitter in the peripheral nervous system, especially at that neuromuscular junction, okay? It acts also in the autonomic nervous system as well, okay? Talk about it binding to those muscarinic receptors or nicotinic receptors, especially in the parasympathetic nervous system, okay, which we're not worried about now, but we'll get there. But it acts as a neuromodulator in the CNS through its connections here, acetylcholine, CNS, in both the brain and in the spinal cord. Spinal cord is still part of your CNS. Acetylcholine. GABA, gamma aminobutyric acid. It is the major inhibitory neurotransmitter used in the CNS. It's a fast-acting neurotransmitter in the CNS, okay? It's an amino acid. It will bind typically to two different types of receptors, either GABA A's or GABA B's, okay? GABA A receptors tend to be you have a greater number of GABA A receptors in the brain, and then in the spinal cord you have a little bit greater number of GABA B's in the spinal cord, okay? So when GABA binds to a chloride channel, it opens a chloride channel to allow negatively charged chloride ions to go into the cell and causes it to hyperpolarize and decrease its ability to generate an action potential, okay? Things like benzodiazepines and barbiturates, Valium, and so forth, they are GABA A or GABA agonists that tend to bind to GABA A receptors. So they're a GABA agonist. They mimic GABA, barbiturates and benzodiazepines, mimic GABA and bind to GABA A preferentially. GABA A are throughout the cerebrum. So like barbiturates and benzodiazepines and Valium, they tend to cause overall much larger CNS depression, like your cognition goes down, fatigue, alertness, all that stuff goes down because you're influencing the whole cerebrum with these. They actually work pretty powerfully for decreasing tone. We often use them in the neuro world for reducing tone, but the problem is they also reduce everything else, including cognition and ability to focus, so they don't really great in therapy. It makes them too tired. They don't want to be as active, so we don't like to give those to people if they don't need them, for other reasons. GABA B receptors, those are primarily more so in the spinal cord, okay, in the presynaptic terminals in the spinal cord, okay, and so so they are linked to ion channels via second messengers that cause inhibition in the presynaptic terminals. Baclofen is a medicine different from benzodiazepines and barbiturates. It tends to preferentially bind to GABA B receptors, so it has less action in the brain. There is still some GABA B receptors in your brain, so some people, when they start taking baclofen, initially they do notice some fatigue and cognitive issues, but they tend to adapt to that, but it has a higher effect at the spinal cord level. So it's better for reducing tone than reducing cognition and other CNS depression. So its effect on tone is disproportionate to its effect on the brain. It's at the spinal cord level because it preferentially binds to GABA B receptors. So most of my patients, if it's purely a tone problem, they'll give them baclofen before they would give you Valium or something like that. Sometimes if their tone is so bad, they'll ramp them up on baclofen to the max level, and if they still aren't getting effects, then they'll add a little Valium in there or something else in small amounts to see if they can modulate the tone even more, but without creating too much fatigue and those kind of things. Glycine, it's an amino acid. It's going to cause it's an inhibitory neurotransmitter. Okay, inhibits postsynaptic membranes, primarily brainstem, spinal cord. Okay, so it's kind of like the GABA of your brain, but it's more in the brainstem and spinal cord. It's one of the primary inhibitory neurotransmitters. It's going to cause that inhibitory postsynaptic potential, but more so in the brain and spinal cord, the glycine. Glutamate, so those other ones we just talked about, GABA and glycine, are inhibitory to the nerve, to to the next neuron. Glutamate's the major excitatory, fast-acting excitatory neurotransmitter. Okay, it's an amino acid as well. One of the key receptors that it activates, the protein receptors, is called the NMDA, N-methyl D-aspartate receptor. Okay, this NMDA receptor has been extensively researched as it relates to neuroplasticity and long-term potentiation. So over time, with glutamate, it will influence how that receptor responds. It can make it even faster acting and those kind of things, and you can have more or less of those receptors. It's not a G protein mediated pathway, but it can still have some plastic effects in changing how effective the glutamate is. Okay. Glutamate, since it's excitatory, if you have major trauma to like your brain, brain injury, gunshot, whatever, if you start ripping open neurons, they'll release all their glutamate stores at one time. So typically when you're talking, you want glutamate to be released at specific sites within specific networks, but not just everywhere within a region of the brain, because if you just dump a big load of, glutamate into some area, all the neurons around it are going to get really active, which is not good. It can cause seizure activity and all those kind of things. But it also causes the cells that are nearby that are in a fragile state. They've just been traumatized. They've been stretched. They've been pulled. They've been pushed. They've been swellings on them. Then you ask them to ramp up their metabolic activity to meet the demand of being excited, and it can cause them to fail. And then that can cause a cascade of events where you start to have more damage to the cells because they're overexcited, but they can't meet that demand. And then you have loss in this area around the immediate damage site.
Is that what is so dangerous about second impact syndrome? Is that
I don't think it's that. I think that's a different mechanism. This happens within the first few hours or days of it happening while you still have some active inflammation and trauma going on. So it doesn't really influence that down the road, months and weeks down the road. So, but that's a good thought. There is some question on, for example, physical therapy. If somebody just had a big stroke, how soon is too soon to start being real aggressive and making their brain work very actively and creating more glutamate being dumped and exciting the system, or how long do you wait? It looks like as long as you're out of a few days, after the stroke or something like that, you can pretty much push people from a standpoint of motor activity that is just motor learning activity, not necessarily cardiovascular. I'm not saying put people on treadmills and push them to max, but lots of repetition, practice of whatever skill you're trying to retrain, not necessarily bringing their heart rate up, but it's after the first few days, you're probably okay. But there's a little window that you got to be a little careful. Like you're not going to go do 1,000 repetitions of some motor activity if somebody just had a big bleed in their brain within the first few days, oftentimes.
Is that where you put someone in a coma and try to kind of slow it down?
Yes. So some part of that can be, induced coma to reduce activity, metabolic activity over the whole body plus the brain. So, yep. Dopamine is another big neurotransmitter that functions as more of a neuromodulator, right, in the system. It has effects on motor activity, especially in the basal ganglia. So that there's those cell bodies that are in that little midbrain area project axons into the basal ganglia circuits, and it can upregulate it, downregulate it, facilitates activity within the normal activity within the basal ganglia circuitry. It's a monoamine. It's also the major source of dopamine is the substantia nigra and the ventral tegmental area. These are both in the midbrain, okay? Front part of the midbrain. Loss of dopamine is a primary cause of Parkinson's disease. When you lose those cells in that ventral tegmental and substantia nigra area, that front part of the midbrain, they die off. Usually you've lost about 80% of those when you first notice symptoms. So you've got extra, you've got redundancy in there, but you lose about 80% of those, and then all of a sudden you start having major symptoms. You probably had subtle symptoms before, but they're just not able to be picked up. Serotonin. Serotonin's a big neurotransmitter, neuromodulator, I should say. It's, again, more slow-acting, influences vast networks of neurons. So what does it do? It helps adjust general arousal levels it actually suppresses some sensory information. Okay, so normal levels of serotonin are important for people that have normal responses to pain. People that have really high levels of pain and chronic pain, they often have very low levels of serotonin. And it also influences their sleep. It's a vicious cycle. If you don't sleep enough because you're in pain, you don't produce the right amount of serotonin, which causes more pain. And so serotonin helps you stay alert, but also at the same time can help suppress and modulate so that you have normal pain responses as they're recognized at the cerebral level, conscious awareness of pain. If you lose that amount of serotonin, then you've got hyperexcitability and responses to pain. Low levels of serotonin are associated with depression and suicidal behavior. Okay, so we do know serotonin is a big player in depression and overall mood. Okay, so setting mood, maintaining normal mood levels, serotonin. So decreases in those is associated with depression and potentially suicidal behavior. It's also a monoamine. Norepinephrine. Okay, norepinephrine also involves big networks of neurons in your brain. So again, you have these cell body areas down in the brainstem that project up into the cerebrum and release serotonin when you need to, release it when you need to when you're active and surveillant, but at night when you're asleep, it downregulates it. Okay, so it's very important for active surveillance of your surroundings, your focus and attention. Highest levels are with vigilance and lowest levels during sleep. It binds to alpha and beta receptors. So remember, norepinephrine is important also in the autonomic nervous system. Okay, so norepinephrine is your sympathetic nervous system, fight or flight system. So not only does it influence the cerebrum, okay, for active vigilance, but it influences the spinal cord where those sympathetic nerves go out and make your heart rate go up, make your respiratory rate go up, those kind of things. It's also a monoamine. Substance P, it's in the spinal cord. Okay, substance P is released in the spinal cord as a neurotransmitter, and in the nociceptive pathway. Okay, so at other sites, substance P can act as a neuromodulator. So it acts as a fast-acting neurotransmitter in the spinal cord for nociception. So substance P is one of the neurotransmitters used when you're experiencing pain. Okay, pain pathways. So when those neurons come in through the dorsal root, back part of the spinal cord, and make that connection in that dorsal horn, substance P is one of the neurotransmitters released there that causes the next signal to go up the pain pathway. Okay, it's one of those, and that's act as a more fast-acting, fast pain pathway. Okay, but it also can act at other sites as a more of a neuromodulator and bind to specific G protein receptors that are also will have an affinity for substance P and will cause more long duration excitation, and that's when we get to more we call the slow aching pain pathways. So you have fast pain pathways that cause the immediate, like, oh, that was hot, and then you feel it, and then later on you feel kind of the throbbing or the pain that lasts longer to say, hey, you still did some damage to this thing. Make sure you don't do anything with that hand right now for the next little while. Those are the slow pain pathways, the G protein mediated pathways that cause that lengthened aching pain, throbbing, aching type pain. But those can also be mediated by substance P. Substance P, it's a peptide. Endorphins, we're going to just talk about them as a group. Okay, endorphins are found in areas with opiate receptors. Okay, spinal cord, substantia gelatinosa in the spinal cord. That's part of substantia gelatinosa is a little region within the spinal cord in that dorsal horn of the spinal cord. Okay, that is important that's one of your first connection points for pain, and so endorphins can help counteract pain. Okay, by decreasing and inhibiting those connections within the substantia gelatinosa. They're also in the hypothalamus. There's an area, periventricular gray matter. Okay, there's near the ventricles. Okay, especially in the third ventricle, just lateral to that, there's a little slice of gray matter on each side of the ventricles. Don't worry about it right now, but and also the periaqueductal gray. There's a cerebral aqueduct that's going down through the midbrain. Okay, that little aqueduct that goes down between the third and fourth ventricle. There's a little bit of gray matter right around there that has cell bodies that secrete endorphins, and those go down and help modulate pain. These are part of our descending pain inhibitory pathways. So they go down, send axons that go down to the dorsal horns in your spinal cord, different levels, and say, hey, quiet down if we don't need to have that high of a pain response, okay? Especially the slow nociceptive pain, you know, try to modulate that. It's a peptide as well. This is from your book here, just showing you, you know, the most common neurotransmitter / modulators, okay? And then their most common receptors that they bind to. So you have the neurotransmitter itself that influences what's going to occur with the next neuron, but also depending on what neuroreceptor they fall on. For example, dopamine, when we talk about the basal ganglia function, when dopamine binds to a D1 receptor, it increases activity through the basal ganglia in what's called the direct loop. When it binds to a D2 receptor, and it inhibits activity in what's called the indirect loop. The net output of that is actually makes the, you know, it increases activity of the direct loop, which is excitatory, and it decreases the inhibitory loop. So the net, you're decreasing the inhibitory, increasing the excitatory, and that makes excitation of the whole basal ganglia circuit. Don't worry about the details now, but I'm just saying that depending on what these bind to, it makes a big difference of its action, okay? And, you know, you guys have already started to learn probably in pharmacology and in previous physio, you know, our norepinephrine are alpha 1s, alpha 2s, beta 1s, beta 2 receptors, would be heart, lungs, you know, those kind of things that, and vasculature that influences sympathetic changes in respiratory rate, heart rate, vasodilation, depending on which receptors they're binding to. Just in case you were curious how you pronounce this, that's mu1, mu2. This is kappa. And what's that one again? What's that Greek symbol again? It just left me. That's gamma. Yeah, gamma. Sorry, thanks. All right. Just real quick, clinical considerations. So, and I've already mentioned some of these. So neurotransmitters, agonists and antagonists. So when you're talking pharmacology, when you're talking trying to influence the nervous system, and oftentimes the autonomic nervous system, your drug is going to either try to mimic a neurotransmitter or block a neurotransmitter. So if it's mimicking it, it's an agonist. If it's trying to block it, it's an antagonist to that neurotransmitter, okay? That's all that we're saying there. Examples, botulinum toxin, okay? If you're botulinum Botox, when you inject that, what it does is it blocks or antagonizes the release of acetylcholine at the synaptic cleft between the muscle membrane, okay? So you don't have acetylcholine coming in, because you don't have acetylcholine being released into the synaptic cleft, okay? So that's why it weakens the muscle. It paralyzes it essentially, okay? So you can use that for, you know, making you have less wrinkles, but you can use it also to decrease tone or clonus in certain muscle groups by injecting it into that. Baclofen, we already mentioned that. It's an agonist. It's a GABA agonist that preferentially binds to GABA B receptors that tend to be in the spinal cord and brainstem more. So it causes that decrease. It inhibits spinal cord activity, so it makes your tone go down in your muscles because it's binding to those GABA B receptors. It's mimicking, it's an agonist to GABA, but specifically GABA B, okay? Propranolol, it's a beta blocker. It blocks beta 1 receptors in the heart, okay, for norepinephrine. So it's an antagonist to norepinephrine, blocking those receptors so norepinephrine can't bind to it, and so that decreases blood pressure and heart rate contractility. So, and your beta blockers. Synamet. Synamet's a drug we give for Parkinson's disease. It is a form of levodopa, L-dopa, that converts to dopamine in the CNS. So you give this drug, levodopa will cross the blood-brain barrier. Dopamine, when you give it, if you gave somebody straight dopamine, it would cause lots of side effects in the periphery, because dopamine also binds to things in the periphery and cause you like your blood pressure just to crash and drop and do kinds of weird things. But levodopa won't do that in the periphery, but it'll cross. It's also a small enough molecule that crosses the blood-brain barrier. It's a precursor to dopamine, and then it'll be changed into dopamine and converted, so it increases dopamine levels in the central nervous system and increases the normal output of the basal ganglia. SSRIs, selective serotonin reuptake inhibitors. So they're the selective of serotonin, and they prevent serotonin from being broken down or taken back up in the synaptic cleft. So if somebody doesn't have a lot of serotonin, doesn't have normal serotonin levels, when they do release serotonin, you want it to stay around as long as possible, so you give it the best shot to bind to the receptors on the postsynaptic membrane. You don't want it being broken down too quickly. So that's what SSRIs do. They try to prolong how long it lasts in that cleft, so it's got a better chance of more of those binding to get the effect of serotonin.
So there's like antidepressants and stuff?
Yes. Monoamine oxidase inhibitors also prevent breakdown of serotonin, but also dopamine and norepinephrine. So they work on all three of these monoamine oxidase inhibitors, because this monoamine oxidase plays a role in breaking down all those neurotransmitters. Okay, so this is specific to serotonin. The MAOIs work on all those. Okay, so you're trying to increase levels or increase the ability of all these to work more normally. Okay, and it's still, anything with modulating these big networks of neurons is really just as much a science as it is an art. So it takes time when you're trying to modulate people's depression, mood, those kind of things, and everybody's nervous system's a little different. So it's usually a trial and error kind of thing, that you have to go through, of dosages and combinations to try to get that optimal balance for somebody. It's really a frustrating and hard process, I know, for people. Real quick, just a few diseases that are really, that neurotransmitters or lack of synaptic transmission is involved with is Parkinson's. It's a dopamine problem. It's a neurotransmitter problem, primarily loss of dopamine. There's a thing called Lambert-Eaton syndrome. So what happens in this is you've got small cell carcinoma, lung cancer, that affects very specific types of cells in the lung. And when they're cancerous, they actually produce an antibody that goes out and kills or impacts calcium channels. And if you reduce or impair calcium channels in those presynaptic membranes, you can't get the synaptic vesicles to move to the membrane to release neurotransmitter. And typically, acetylcholine in this case, so they've got weakness in the muscles because you reduce you damage the calcium channels, so you can't get the synaptic vesicles to bind and move to the presynaptic membrane to release, in this case, mostly acetylcholine at neuromuscular junctions. Okay. Myasthenia gravis is a little bit different. Myasthenia gravis is an autoimmune disorder that creates antibodies that damages or kills off nicotinic acetylcholine receptors on the muscle cells. So Lambert-Eaton syndrome, antibodies damage the calcium channels on the presynaptic membrane, so you can't get the vesicles to move to the membrane. But myasthenia gravis creates antibodies that damage the postsynaptic membrane and the acetylcholine receptors on the postsynaptic membrane of muscle cells. And you tend to see when people have myasthenia gravis, it tends to be most obvious in muscles that have to contract all the time. So muscles of the face, the eye, and some of the proximal muscles, girdle muscles and things that tend to be on all the time. Because if you're having to activate it all the time, and you don't have enough receptor sites, it's more obvious with muscles that have to be turned on all the time. If it's a muscle that you just activate briefly, occasionally, like a larger muscle group, you don't notice it as much. But when you have to have a muscle that's turned on all the time, it fatigues out more quickly because of this. And then depression. Depression is, something that's a very complex issue, but it can involve abnormalities in levels of any of these: serotonin, dopamine, and norepinephrine. Okay, and that's where that whole trial and error process. There's no really way to do like a blood test to check and see what your exact serotonin, dopamine, and norepinephrine levels and be able to tailor it specifically. So based on the person's symptoms, behaviors, the doctor takes their best guess from their experience, what's worked for them, and then they go from there. And how do you respond to it? And it takes oftentimes 1 to 2 weeks for these changes to occur, because you're talking about changing, G protein mediated pathways and receptors and putting new protein channels in there to get the maximum effect from these medications. And that's also why you have to wean off of them too. You can't just go cold turkey, because your nervous system is now functioning in a different way and can cause all kinds of problems. Down, I don't know if I've seen that picture in that edition, so.